Good evening, everybody, and welcome to tonight's Facebook Live session. My name is Sam Chakosky, and I'm the Sales and Marketing Manager for Urology and Continence Care today. And I'm just going to run through a couple of bits of housekeeping before we get started with today's session. So today's session is titled Intermittent Self-Catheterisation, Supporting Patients. And our speaker today is the wonderful Polly Weston, who is the team lead at Baywide Bladder and Bowel Service. And at the University Hospitals of Morecambe NHS Foundation Trust. Welcome, Polly. So really looking forward to this session. Really looking forward to this session. It's sponsored today by BD, so a big thank you to them for supporting this event. Without support from people like them, we wouldn't be able to put on these events for free. So a huge thank you to them for their support as well. So certificates will be available at the end of tonight's session. We'll post a link in the comments section, and there'll also be a link on the screen. So you'll be able to follow that link, fill in a few details, and you'll get a CPD certificate for your revalidation. We'll also have a live Q&A at the end of today's session. So throughout the session, when Polly's speaking, please do leave your comments and questions in the comments section on the Facebook video. In the comments, our team will be answering any questions you've got about anything. But if you've got anything for Polly that you'd like to ask her, I'll be back at the end for a live Q&A asking all those questions. So feel free to ask as many as you like throughout, and we'll get through as many as possible at the end. Do bear with us if there are any technical issues. Obviously, you can see we are filming this remotely, as I'm sure you're all very used to. But if there are any technical issues, like I said, our team will be in the comments section to advise on that, and I'm sure it won't be long before we're back up and running. So without further ado, I will now pass you over to Polly, who's going to present on intermittent self-catheterisation, supporting patients, and I will see you for the live Q&A afterwards. Thank you very much.
Thank you, Sam, for that introduction, and to BD for inviting me as well. It's my pleasure to spend a little bit of the evening with you, and thank you to everyone that's joining. I'm sure you'll find this interesting and hopefully worthwhile. So as Sam says, my name's Polly Weston. Some of you might know me as I am the chair of the Association for Continence Advice, and my day job is the team lead for the Bladder and Bowel Service at the University Hospital of Morecambe. And really I bring hopefully some of my experiences and the work that's happening within my team at the moment, and I'm really happy to share some of that with you. So I'm going to start by exploring what the learning objectives for today will be. And really what I've identified is 3 learning objectives. The first one is to determine a pathway for avoiding dysfunction, and then looking at best practice treatment plan for intermittent self-catheterisation, which from now on I'm going to refer to as ISC, just to make life easier. And finally, looking at the benefits of collaborative working. So moving on, we'll start by exploring what bladder assessment should look like. So within working practice, we know that a continence assessment is essentially a care plan based on bladder problems and a diagnosis. And in order to fully determine a diagnosis, we suggest that nursing staff need training to underpin knowledge and skills in order to make the correct decision of what the bladder diagnosis should be, and therefore follow a care plan to look at treatment for that. So the 4 main bladder diagnoses being stress urinary incontinence, overactive bladder syndrome, voiding dysfunction, and functional incontinence. And we're going to be focusing on voiding dysfunction today. So before we do that, let's have a look at the prevalence of bladder problems. And you might be surprised, but actually they're incredibly common. And we have found that probably underreported due to the taboo nature of bladder, discussing bladder problems, particularly in the UK today, where we are quite a stoic and private community. And therefore, what we know is that it's 1 in 4 patients will experience bothersome bladder problems in their lifetime, and 1 in 10 bowel problems, as far as the reporting we can find. And we also know that actually that's more people in the UK than present with asthma, diabetes and epilepsy combined. And when the Bladder Interest Group put that piece of work together, it was really quite surprising for people like myself working in a bladder and bowel service, where it made us think to ourselves, we've got the statistics and evidence here. And actually what that shows is our bladder and bowel services set up with the correct staffing to meet the needs of our population. And when you compare your staffing with the staffing in other specialist services, such as respiratory services, diabetes services, will you find probably that your staffing levels fall short of theirs? So I think actually it's food for thought for all of us, really. So let's focus now on voiding dysfunction and actually think about some of the common causes for voiding dysfunction. So first of all, we're going to start with obstruction and actually thinking what can be causing this diagnosis. So things like fecal impaction, chronic constipation, or whether there's something else underlying like an enlarged prostate, urethral stricture, a tumour, or some kind of prolapse. And those are considered red flags and will need onward referral for specialist treatment. Then we're looking at underactive bladder. And within this category, we're looking at patients who basically have an inefficient bladder. The bladder only has two jobs. The first job is to stay in its relaxed state whilst it fills with urine. And the next job is for it to contract so that urine can be emptied from it. So if it loses its efficiency and is unable to contract in an efficient manner, then it might actually mean that patients are having a problem voiding. And this is quite common with patients with neurological problems, such as Parkinson's disease, multiple sclerosis, diabetes, or following a stroke. And thinking about the next group, which is detrusor sphincter dysynergia. It's a very similar scenario, but more of a loss of coordination between the bladder and the bladder muscle and the urethral sphincter. And this can also affect people with neurological conditions. So basically, there's a disconnect between the brain, the spinal cord, and the bladder. And for anyone there thinking, how do I know if this is the cause of my patient's bladder problem, there's some really useful European guidance. The European Association of Urology puts out some guidance, and within that guidance it really clearly explains every single neurological diagnosis and the types of symptoms, bladder symptoms and voiding dysfunction that you can expect to go with it. So it's a really useful further reading, and if you are interested in the references for that, they will follow this meeting as far as I'm aware. And so moving on from looking at the voiding dysfunction, let's have a look at what symptoms the patient will present with voiding dysfunction. Some of these symptoms on the screen, such as frequency of micturition, urgency, getting up in the night and passing urine in the night, which is nocturia, and nocturnal enuresis, are very common in an overactive bladder as well. And so therefore it's really important that you get your diagnosis correct. You can also find patients have dribbling incontinence, recurrent urine infections. This is very common actually for patients with voiding dysfunction, poor flow and after dribble, and hesitancy before they pass urine. So how do we know that it's definitely a voiding dysfunction? Well, it's important that we get the treatment pathway correct. So the investigations to underpin the diagnosis are firstly an ultrasound bladder scan, and secondly, identifying that residual urine. And some patients will have a one-off residual urine that's unexplained. They might just be nervous at the appointment. There could be another factor involved with their health. So you really need to think about at least 2 occasions where the residual urine is greater than 150 mils to think about whether the bladder is draining correctly. A lot of patients in those neurological categories, you'll probably find the residual urine is far greater than that, even on the first time that you do the ultrasound bladder scan. So moving on, think about the least invasive treatment first. And it's really important that we take our patients down a pathway wherever possible, promoting self-care and looking at the least invasive treatment first. And we know right back from the beginning, the history of nursing, that Florence Nightingale always tells us that our aim is to do no harm. So thinking about the least invasive treatments, first one would be the double voiding technique, where you're teaching a patient to press or pass urine and then press in that lower abdominal area, similar area to where you're scanning, and actually try and lean forward and press and see if they can pass further urine. The next step up from that is to stimulate that lower area, and some patients that's a lifeline, and it does actually prevent them from having intermittent self-catheterisation. But actually those Queen square bladder stimulars do make a little bit of a noise. They're battery operated, they're only a handheld device. Those of you that haven't heard of them, they're invented by Queen Square Hospital in London, which is a neurological centre. And actually for some patients, just stimulating that lower bladder area helps them to pass urine. It's really, really good way of preventing an invasive procedure. But the next step up from there is an invasive procedure, and wherever possible, best practice being ISC, and if required, indwelling catheterisation. Moving on from there is whether patients would need onward referral to consider pessary surgery. But we're really going to focus today on that middle category of trying to teach ISC and wherever possible, avoid an indwelling catheter. So let's have a look how we are guided nationally. Well, the RCN reviews its guidance very, very regularly. And I really do feel this is an important document to help clinicians everywhere, wherever they work, to actually consider their practices and ensure that they review their practices regularly too. We know that guidance such as the RCN catheter care guidelines actually help to inform local policy as well, and certainly I would suggest that when you are looking at policy and policy review, a collaborative approach is best practice. Think about who sits on that policy group, and I would suggest that the best groups of people to come together is somebody leading from a bladder and bowel service, a urology service, and also infection prevention, to make sure that we're meeting the entire needs of the population. So why would we suggest ISC as best practice? Well, I'm sure you can appreciate there have been many, many studies carried out over the last few years or longer in the UK to actually think about how we can prevent harm. If you only need to look through the British Journal of Nursing and the Nursing Times, and the ACA actually also produces a regular newsletter which promotes some really any good recent research articles that may have been in either of those journals. Within those journals, what we really find is that actually we're promoting best practice, and best practice means that we are trying to prevent danger. And we know that catheterisation could present patients with significant danger if they've catheterised for long periods of time. So for instance, we know the incidence of urinary tract infection goes up for patients with an indwelling catheter, and the longer that catheter stays in place, the higher the risk. We also know that it's a key recommendation that we use indwelling catheterisation only when all other techniques and management options have been considered and have failed. So let's have a look what other guidance suggests to us. It's important that we think about ISC as the gold standard, and certainly NICE guides us to that and says that it's gold standard for urinary drainage. It's also important that we remember that it's a useful tool for voiding problems, and actually there's a range of voiding problems that we can use it for, as well as avoiding dysfunctions such as using it for disturbances or injuries to the nervous system, non-neurogenic bladder dysfunction, and also intravascular obstruction with incomplete bladder emptying. So it's just thinking broadly about why ISC is best practice and remembering that gold standard of preventing harm wherever possible. In April of 2020, some key recommendations were launched. And at that point, the best practice statement was brought out for urinary catheterisation. This was then launched at ACA conference in May as well. And at that conference, there was a huge interest in the room, people actually realising that this best practice statement could be useful and helpful for teams actually looking at their local policies. This statement focused on 3 key areas. The first area is communication, and it really asks staff to really consider what is documented and to use electronic patient records in a clear and concise manner. To actually think about the language that is used, not just in patient documentation, but in the consultation style with patients, and to make sure that language is understood and that patients are included and that it's a two-way journey. And the third thing under communication was to reconsider passports. The concept of a catheter passport has now been considered in many areas and has been in place in some areas for a number of years. But the problem, there are so many problems with a passport, and we do feel now is the time to consider an electronic version so that it's safe and robust, and also can be kept up to date by the clinicians and the patients more easily. The next part of the best practice statement is training and education, and this is really important, thinking about the journey the patient has in any part of their holistic care. Are trigger questions being asked about bladder and bowel? Are opportunities being made to actually consider whether the patient has a bladder function problem? And with that in mind, making every contact count. If training in catheterisation was mandatory for all clinical staff, we are convinced that practice would be safer. The third key area that is recommended in the best practice statement is thinking about patient empowerment. This is a really key part of NHS work right now, when we're really focusing on anything that we can do to improve self-care for patients. And patient involvement and actual coaching techniques in order to support patients to reach self-care is fundamental now. The NHS will only become more and more burdened, and patients now need to actually be encouraged and coached to take more responsibility for their healthcare. Moving on, we also know that Skills for Health have always had some national occupational standards related to catheterisation. These standards are a really useful training tool, and they're really easy to look up, and also they could be quite a nice, useful aid memoir when you're maybe newly starting intermittent catheterisation, or if you're somebody that's informing at policy level and wants to actually look at what best practice looks like. It's a useful training tool at all levels, from novice to expert, and it's something that we can always revisit as well. So knowing the guidance is out there, I think it's important that we have a little look at the pressure on the NHS and thinking about, well, what does good look like? And under the current situation that the NHS is in, how can we achieve good practice? We know that it's very, very time consuming to build a rapport with your patient, and establishing that therapeutic relationship is fundamental to build that patient's confidence in you, especially as bladder concerns are such a taboo subject, and doing ISC is a really invasive procedure. This is an awful lot for a patient to digest and accept. And this really makes you think about how you're going to build that therapeutic relationship with the patient, how many times you'll see that patient, and all of that is very time consuming. So this really takes us back to what I've just talked about. We should all really hold up this best practice and make sure we think about putting the patient at the heart of everything that we do, and consider how we can actually work in a practice that is good quality care rather than care that is actually possible, because the NHS unfortunately doesn't have the time for us to build that relationship that we would like. So the longer we spend revisiting that patient, the less we're getting through our waiting times. Let's have a look at those pressures now. And actually the pressure on the NHS clinical resources has never really been more, because post COVID, we've all got recovery targets, and the waiting lists have grown longer and longer. Some bladder and bowel and urology services were redeployed through COVID, and some staff actually have come back to staff changes. And staff changes means a period of training clinicians to the expert level that we need them to be. And this can all be quite time consuming. Recruitment in the NHS is a really time consuming factor as well. And actually getting recruitment right, whilst it is lengthy, it is important that you get the right team and build the right synergy within your services. So looking at restoration targets post-recovery and looking at having a team with the right knowledge and skills often means that the added pressure on the NHS means that the waiting list doesn't actually start to come down in the timely manner that we would prefer. So it's important that we have a look at, well, what does safe staffing look like? And the Department of Health's Good Practice in Continence service is really clear. That came out in the year 2000, but it clearly recommends that for specialist nurses, they should be working to 1 whole-time equivalent per 100,000 in order to build their service. And that's something that's 22 years old now. So it's possible that even if you're at that level, that's outdated with the work we're doing. But a lot of services might not even have that weighting of clinicians for the population. It might be that that's a useful measure for you to think about a business case in your area. Have you even got anywhere near that staffing, let alone do you need more? And think about that slide I talked about earlier of whether our bladder and bowel and urology services are whether they're actually meeting the needs of the population in comparison to some of the other services that are emerging now, such as respiratory and diabetes. When we think about all of that, the pressures of the NHS, the time it takes to recruit, the time it takes to create experts within your team, it really makes you think about how services can be maintained in the long run. And the All-Party Parliamentary Group has been a real support to focusing on bladder and bowel services and urology services. This All-Party Parliamentary Group focuses on continence care, and actually it talks about a cost-effective commissioning guide. And this is a really useful guide to ensure that when you're procuring a continence service, a bladder and bowel team, that it is actually fit for purpose for the specialist team that you require. And it might be that for some of you, that's useful information that you can take back to your workplaces. Staff development is vital, and actually whether you look at national guidance or local guidance, I'm sure you're aware that your staff need knowledge and skills and competency, and we're on a lifelong journey. And so therefore, whatever service you're coming from, it's important that we keep learning, we keep developing, we share practice, and we keep growing. And this in itself is time consuming as well. And it's really important that we think quite laterally and keep focusing on what quality and safety risks are out there. We know that the psychological burden our patients carry of having an embarrassing condition is actually a huge concern. Some patients take years to come forward and admit they've got a bladder problem because it is just so embarrassing. We also know that actual physical harm can actually be caused because of some of the risks that bladder dysfunction, particularly incontinence of urine, can cause to skin, and also a worsening of the bladder condition in the time it takes for patients to come forward or wait on our waiting lists. And all of those things means a reduced quality of life. And we know it takes a long time for patients to admit they have an issue, and then they're on our waiting lists. And within this time, they're often starting to feel quite socially isolated. Some patients say, well, I don't go out now because I need to make sure I'm near the toilet, or I'm always toilet mapping my way around, and that's very stressful, and it can lead to a burden on their mental health. Actually, during COVID, Lancashire Adult Safeguarding Services released a briefing paper talking about a safeguarding issue based on long periods of isolation to causing mental health problems in themselves. So if imagine you've got an embarrassing taboo subject like a bladder problem behind that as well, you can imagine that patients can actually get to the point where their quality of life has reduced massively. We also know that staff morale is a huge factor in our workload, and actually if you've got an overwhelming workload, and it can actually be stressful for staff, it can be overwhelming for everybody working within the team, and that's not sustainable. It means that staff resilience is knocked and staff really feel quite stressed at work. So it's how to come together in a way that staff feel supported in with a workload that's manageable, so they can actually enjoy the journey that they're having in being a specialist bladder nurse, and actually supporting the patients in the way that they're trained to do. The pelvic floor report, which was launched in 2021, right in the middle of COVID, really talked about making sure we future-proof our bladder and bowel services, and really thinking about how we can plan succession so that we don't have these gaps, particularly in the NHS. And although that paper is fundamental and important to us, it is very, very difficult when often key decision makers within the NHS are not connected to our service, and often these key decision makers aren't even clinical staff, so it can be complicated. But we do know that within the NHS right now, January of this year, there was 40,000 vacancies of nurses in the NHS alone, and we know that will have grown since January. So we're under immense pressure, and that pressure is rising. So that brings me on to talk about collaboration. I think you've probably got the picture. The NHS needs support and help more than ever. So let's think about what collaboration could look like. Well, we know that the only thing we can rely on in the NHS is change and development. People don't stand still, staffing doesn't stand still, services develop, technology improves. There's lots of positives within change in the NHS, and therefore we need to think about embracing change in how we consider our colleagues to be. And one of the ways forward that I found really useful was I built a very good synergy with one of the reps that works for a company, BD, and she was very, very supportive and constantly showing us that she was professional and knowledgeable and reliable. And within her rep role, we got to know her very well and felt supported. And it was just a consistent, reliable technique that she used that made us feel we could at least listen to her ideas. And one of her ideas was, why don't we work more closely and have some nurse support? It took a while for me to get my head around that, because I really felt in my heart of hearts that my team could do this well themselves. That's what they're trained to do, and why would we give that work away? I don't want to de-skill that team. But actually I realised, yeah, I don't want that overwhelming group of people who are unable to see the wood for the trees, and we've got to think differently. So we thought it was worth exploring the idea. And so we actually then thought, okay, well, how are we going to do this? We need to consider a confidential transfer of clinical information and make sure that information governance was upheld, and actually think about how we would share that care and what point that care would be shared, and we would need to review that regularly. So we decided, okay, let's have a look at that for a start. We knew there were some risks attached to that, and those risks are important to be verbal about so that you can minimise them. Risk number one was a breakdown in communication between the NHS team and this corporate nurse. That's a problem. The second risk is if we had any breach of information governance. And these two risks were a huge concern to us, because we felt very protective of our patients, their safety, and at the end of the day, the patient is at the heart of everything we did, and our prime goal was to make sure that their care was optimal. But we managed to mitigate those risks. We knew that we were working with a nurse who not only was registered with the NMC, was following a code of conduct, but was also competent and expert in her field. We knew that she would use the same range of techniques to teach ISC that we would, that she would also be updated and learning and on a lifelong learning journey. And we knew that actually we needed to actually have faith that rather than thinking about this as a different company, we need to consider this to be an added member of the team. And that way we felt that we could focus on the benefits. The benefits really were first of all, an opportunity to increase our capacity. And that was fantastic, because every time that a patient moved into this shared care, we had more opportunities to start seeing new patients, which was wonderful for us. And it helped us to reduce, start thinking about reducing the number of contacts that the NHS nurse saw per patient, because we had support with that. It also, in the long run, will start to reduce our waiting lists. And it's a real difficult one for us to measure, because in among all of this, we've had new staff, lots more people to be trained, but actually we know that actually it is freeing us up to reduce our waiting lists, because we can see more patients, more new patients. Building the synergy with the corporate nurse was a really important benefit. And we knew that it would only work if we felt that two-way synergy between my team and the nurse we're working with. What we hadn't realised was the unforeseen benefits. That patient experience was fantastic. The patients are obviously really, really pleased that they're seen in a timely manner by this nurse, and that their expertise means that they actually get the time and effort and put into it by the nurse, and the solutions to improve their quality of life. The other unforeseen benefit, which actually I had no idea that this would be so vital, was that actually this nurse became an excellent role model. So actually, not only is she seeing the patient, she started to undertake some joint visits with some of the newer specialist nurses within my team, and therefore became an important member of the team, training and developing these staff. So we weren't de-skilling the staff, we were actually making sure they had the opportunity to learn and develop, not just from some of the more expert staff on the team, but from this nurse. And therefore we knew that this nurse was taking a really broad approach and looking at the right products that they chose for the patient, and not necessarily always guided by the patient and their needs, and always very individual. And those benefits have been vital for us, because actually it has meant that staff can actually learn a range of consultation styles. And as new specialist staff come to my team and they're looking to develop their own consultation style, it's useful for them to see more than one other consultation style to ensure that they get a range of ideas before they're on their own. So we could improve that referral to treatment and discharge target, and that was a real final benefit that we thought was really measurable as well. So what was our pathway for shared care? Well, we realised that what was happening was, because we made sure we'd done 2 scans on the patient and we knew that that's definitely avoiding dysfunction, by the time we built that rapport and were seeing that patient for the second scan, really we would want to encourage the patient to have their bladder drained at that time. Because don't forget, we're assuming this is urine until the intermittent catheter is inserted to confirm it's urine. It could be another red flag. And it's actually important that that drainage happens wherever possible on the second appointment if the scan indicates avoiding dysfunction. So we realised that we're so far down that therapeutic journey that we actually now need to start trying to encourage that patient to do it themselves if possible, or we're draining the bladder for them. One way or another, we're invested in that patient now. So we knew that we needed to take a step back and hand that patient over after the first scan, and move that patient through to the collaborative working with the corporate nurse, and then let them build the relationship at the second scan, and if needed, drain the bladder then. So by doing that, they actually started the entire ISC journey with the patient. The only thing was that BD, in this case, were prepared to take the risk of the number of patients on the second scan were fine and didn't need bladder drainage and didn't need any further on the pathway. They were happy with that. So we all felt that was the best way to hand the patients over. And what we did was we then received back a clear documentation of what exact training and device choices and patient involvement that has happened as a result of that. One of the things that we realised at that point was that patients really benefited from that handover of care. They didn't mind. It was just us being precious, assuming that we would need to do that second scan and that care. But actually, once we made that decision on the pathway to hand the patient over after one scan, it has been a great benefit to the patient. So I'm going to just talk a little bit about a patient story now. And this is a really good example of somebody. She was just a 50-year-old woman, actually, who had avoiding dysfunction. We knew that. But actually, she was a bit of a regular DNA. She just didn't come to appointments. She was really stressed and anxious, housing issues as well, which was an added burden to her. And she also had a breakdown in her relationship with her family and neighbours. And what happened with this patient? The patient was handed over to the BD nurse, who then worked with the patient in an individual basis to try and make sure appointments were suitable. And actually, she provided a listening ear and realised that she had time to uncover the root of the anxiety and the housing issues and the problem with the neighbours and family, all kind of interlocked into the stress and anxiety of the taboo problem with her bladder. And actually, just time to break down those barriers and support that patient meant that not only was that nurse able to support that patient with her ISC treatment and becoming independent with that treatment, but she also helped her to accept her healthcare issue and actually build up those relationships she needed with her friends and family and calm down some of the anxiety she had around that. So it makes me really feel that that patient story made me realise the time and effort as well as the clinical skill were equally important in this case. So finally, I'd like to invite you all as a call to action to think differently if you can, and think about different ways of working where the NHS can actually be supported by another provider, and actually embrace a different approach to working with corporate colleagues, and actually consider that they are our partners and we actually can build a good synergy with people from other organisations. And by working collaboratively with nurses from different organisations, we can actually improve the patient journey. Thank you.
Brilliant. Thank you very much, Polly. Really interesting session, and we've had lots and lots of comments and questions coming through. So we'll get to the live Q&A very shortly. But thank you very much for that presentation. That was brilliant. On your screens, you should see some contact details for BD. You can see the website, the email address, and the phone number. You can contact them for any more information that you might need. The links for those will also be in the comments section, and we'll also put this up at the end of the Q&A as well, so you don't miss it. So moving on to the live Q&A, we've got lots of questions, like I said, that have already come through, but please do keep submitting your questions if anything else pops up, and we'll move on to those now. So question 1. We generally do 3 bladder scans at different times of the day to get a better picture. What are your thoughts on this, Polly?
There's so many thoughts. I've met teams who scan more than 3 times. I've met other teams that only scan once. And actually, at the end of the day, by the time you've found residual urine 2 times, really, if you don't drain that bladder, you're never going to know if it's actually urine. It could be, for females in particular who haven't had a hysterectomy, it could be some kind of fibroid or cyst or something. So I do think at the second scan, by going to a drainage, you can confirm your diagnosis. Yeah. Brilliant,
thank you. So question 2 is 150 mils residual the amount when you would confirm voiding difficulties? As out in the community, when we perform a trial without catheter, our current standard operating procedure allows residuals of 300 mils.
So it's really difficult. It's about the patient's symptoms and whether they're symptomatic. So if somebody's not symptomatic, if you speak to a urologist, they might say, well, if they're not symptomatic, half of Britain could be walking around with a bladder. So we're talking about patients who are presenting with a bladder dysfunction. So it's thinking about, are they going to the toilet frequently? Are they getting frequent urine infections? What type of symptoms is causing them to talk about the bladder? If they are perfectly calm and happily walking around with a bladder full of urine, then it's not an issue for them. But actually, we would say under 150 mils, we can't really call it voiding dysfunction. So therefore, those symptoms don't warrant an invasive procedure. But it's about matching the symptoms and not just the findings of the scan.
Brilliant, thank you. Question 3, do patients have support when they go home after they have started ISC?
So our patients all at home, so they're found at home and they stay at home. So a patient who might have been found in an acute care organisation where they're in hospital, if they're found to have an indwelling catheter removed, I would presume the urology specialist nurses would teach ISC. And I think you're quite right. What happens when they go home? What if they need further support? I think there's going to be a lot of other areas where collaboration could be really useful in the future, where there are gaps now and unmet needs.
Yeah, of course. And on to question 4 then. Are there any detrimental effects of ISC if ISC is prescribed 4 times daily as opposed to only being done once or twice daily? And is there any damage that this may cause?
So the number of times a day should be determined by the amount of urine in the bladder and the symptoms. So if somebody has a larger residual urine, when you think the bladder holds approximately 400 mils, some bladders hold more or slightly less than that. If you say somewhere between 400 and 500 mils is a full bladder. If you're getting large volumes in those residuals and you think about what normal looks like, normal urinary pattern is to go to the toilet approximately 7 times in 24 hours. So actually doing intermittent catheterisation up to about 4 times a day would be somebody who has very little ability to void. So somebody who is voiding but just building up some residual through the day is more likely to only do it once a day. And then you build up more frequent, up to about 4 times for patients who have less of an ability to void a urine themselves.
Brilliant, thank you. Question number 5, how did you get around the issue of NHS tender requirements and enter into your partnership with the BD nurse?
So we don't have any tender. We are in the process of a formulary, and that's really about using the products that are chosen by the procurement and formulary team, which at the moment is just in its, it's been in its initial stages for quite a number of years. But actually, from a tender point of view, this isn't a tender to support. This is actually one of the benefits of using a company who has nurses. So I'll be honest with you, Sam, a lot of nursing teams working for corporate are probably being paid for because they are actually having a prescription that's going to home delivery via that company. So traditionally, sometimes prescriptions might have gone to the GP. If a prescription goes to the GP, they've not got a team of people behind them to support that patient. They don't have experts who understand what to do if it goes wrong. They don't have a team of people you can ring up at the end of the phone. They certainly don't have a nurse that could go out and troubleshoot that. So actually, for me, it's not about a tender. It's about it's a benefit of the prescription being home delivery.
Yeah, definitely. Question 6 then, what are the possible complications for ISC patients if they are not well trained?
So one of the big complications is urine infection if they're not draining their bladder regularly. And we know that urine infections and particularly catheter-acquired urine infections for indwelling catheters, but urine infections in their entirety are a huge issue across the NHS now, and approximately 20% of sepsis comes from that. So the potential harm for someone having regular urine infections is a huge concern. Yeah, so not draining your bladder could cause you to become unwell.
And question number 7, how do we know what ISC size or style of catheter to introduce to a patient?
That's a real skill because there are an awful lot of catheters out there, and some people will be led by local formulary, and within that there should be kind of like a group of products that are considered like first line and a group of products that might be a bit more complex. But the whole point is to think about your patient's dexterity and ability, whether the patient has the ability to learn by touch, which would be fantastic, that's our gold standard, or if not, do they need to use a mirror? Can they drain their bladder over the toilet, directly down the toilet, or into a vessel, or do they need a set, which means it's attached to a bag, in which case they is the position that they need to do it on not in the bathroom, or can it be in the bathroom? So actually that's about the expert skill of the practitioner, making sure that the ISC is optimal for that individual.
Yeah, brilliant. And do the patients need to purchase their catheters, or are they given to them for free?
So every service will run their training differently. In our service, we have some products for them to trial, and we like our patients to have seen at least 3 different ones. What we don't want to do is show them so many that they're mixed up and they can't remember the first one. So we gauge that patient, find 3 that we think might suit their needs, and then by the end of that session, we want them to be trialing one of those. And the idea is that it's a prescription. They're a prescription item, and therefore the only cost to the patient is what they would pay for their prescription. Yeah. Brilliant.
Thank you. And thank you for these answers. They're really insightful, and some fantastic questions coming through. So do keep submitting them. If we don't get through all of them, we will answer them following the video in the next few days as well. So question number 9, would increasing ISC frequency help in reducing post-void residual volume and frequency of recurrent UTI, impacting on kidney infection?
Yes, definitely. I mean, again, depending on the volumes, if you've got somebody who has a bladder residual urine of about 150, 200 mils once a day should be enough. And actually thinking about the symptoms, has that, as well as reducing the potential infection rate, it should actually reduce their symptoms. So it's thinking about, well, do you remember that slide which I put all the symptoms on? Have those symptoms start to improve? Are you getting less urgency? Are you getting less dribbling incontinence? And actually thinking about the patient's quality of life as well. So some of it might be a matter of thinking about what the patient can sign up to. So a lot of nervous patients need their first goal to be achievable, helps give them confidence. So it might be that they're saying, well, I can only do it in my own home, in my own bathroom, privately. Other patients feel capable and confident to be more out and about. And a lot of devices are designed for the modern life now, where we might have to perform this in somebody else's home or in a public area, such as if they've gone to a hotel or a different venue for the day. But I would say the whole of that, the whole point is to reduce harm, as they asked, and also reduce the patient's symptoms.
Brilliant, thank you. Question 10, what were the challenges for ISC patients during the COVID crisis?
So the challenges were horrendous because we weren't seeing them. And so patients who were already known to us, we might be able to talk to them on the phone, but our service was minimal because a lot of our service was redeployed, as I'm sure a lot of services were nationally. And some of our staff were able to just give some telephone consultation, but we weren't actually able to diagnose any new patients because we didn't see them. And that examination and that blood scan is fundamental to actually confirm your voiding dysfunction diagnosis. So the impact on patients is horrendous because they become more isolated and their problem could have actually got worse. And I think some patients may have actually become unwell as a result of it. We may never know. You know, there are patients that are discharged from our service before we've seen them, you know, for what we don't know the reasons why. But I do think some people do try and manage for a lot of years before they come forward and have a series of infections, and it's that kind of thing that makes them think, I need to speak to somebody about this.
Yeah.
But COVID just held weight to that because there was no one to talk to.
Yeah, and it must have been extremely challenging for yourselves as well as the patients, but I can only imagine. So at number 11, what are some of the common reasons for ISC use?
So in a bladder and bowel service, the most common reason is because of avoiding dysfunction, to drain the bladder, to keep that patient safe, to prevent harm from infection. But the The ISC can be used to maintain urethral dilatation as well. And a lot of urology services will instigate that with patients who've had where the urethra has been narrowed due to prostate problems. And also other installations can be used by teaching the patients ISC. But in our community care, it's mainly used by patients who are capable of undergoing catheterization themselves. But on some occasions, we do try and use it where we would teach the district nurse and request that they start off that intermittent catheterization process with the patient. So we would choose the device, work with the patient, the district nurse might do that drainage, because we're avoiding an indwelling catheter whilst we're teaching the patient to be independent. So sometimes it is just a useful way of preventing an indwelling catheter whilst you try and teach the patient how to be more independent. On the most part, avoiding a long-term use of indwelling catheters is probably the best. Well, that's what the best practice statement's all about. Yeah.
Brilliant, thank you. So I think we've got time for a couple more questions. Number 12, do you work closely with your local urology team? If so, can you give us tips on collaborative working in practice? And I know you touched on collaborative working and how important that is, but do you specifically work alongside your urology team as well?
Yeah, now that's a really good question. I think that is a really, really important question, because if everyone worked in isolation, we could all be reinventing the wheel. So the urology team and ourselves in infection prevention are equally responsible for the catheterization policies and procedures and clinical guidance for all the staff, all the nurses and in the community and acute wards within our area. But actually, prior to COVID, we used to meet with them 2 to 3 times a year, just for an hour or two, just to make sure we're all on the same page, have an understanding of what types of things to refer to each other for. And we're just getting there again. COVID has seen a change in my team and the urology specialist nurse team. People have moved on, new staff have come in, and now's the time to regroup. So we've got a meeting planned in a week's time. We're really looking forward to that, and actually coming back together, look at how collaboration can be useful for us, and actually to use it as a little bit of MDT. So again, prior to COVID, that was all face-to-face. And actually we had good connections with our urology consultants as well. And we're just getting that back. And it's probably going to take time to get to know each other again, new faces, new people, but essentially it's safer to work together because there is overlap, and I feel that we can't work in isolation. We need each other's ideas and opinions and professional respect really for each other.
Yeah, definitely, across all walks of life, I believe. So question 13, and I think this will be the last question. So again, thank you very much for all your answers. Do you think local formulary restrictions limit patient choice and compliance? And this particular viewer says, in my practice, we are not governed by formulary and our compliance with ISC is very good.
Do you know, ISC compliance is a real tough one, because once we've got somebody independently doing ISC, we discharge them. And then they're not under our care any longer. We can't keep them on forever. And therefore, we don't know what the long-term dropout rate is in our area. We've not looked at that. But I can say that the formulary, in the most part, is to guide the ward staff. So a lot of the formulary will be the indwelling catheters, the bags, and just making sure they're safe and they've got the right products for the right patients. It's much less prescriptive for the specialist urology nurses and bladder bowel teams, because it's really important that we do have our ability to make those decisions based on an individual basis. I think she's absolutely right. Ultimately, what you're aiming for is a patient who will comply long term, keep safe, keep well, and keep independent. So it needs to be as broad as we can make it. Yeah.
Fantastic. Well, thank you, Polly, again. Some absolutely amazing insights there, and it's been great to have your expertise. I'm sure all our viewers will will agree. So I'd recommend. I've seen lots of comments and various things coming through on the feed. So I'd recommend having a look back through them and seeing all the nice things that people are saying about the session today. So thank you for all your answers there. A big thank you again to BD for their support for the event. And just a reminder to contact BD, and for more information about their nursing service, you can visit isctraining.bd.com. And the links will be on the screen and in the comment section as well for that, as well as the phone number and the email address as mentioned earlier. So the certificate link should also be on the screen now, and also in the comment section. Lots of links for you. So you can download that certificate, and that can go towards your CPD for revalidation. The recording of this session will be live on our Facebook in the next hour or so. And it will also go onto our website as well with the slides. So you'll be able to look back and take any notes and enjoy the session again. If you've missed any of it too, you'll be able to watch it back in full. Do make sure you're following our Facebook page and subscribe to our website as well, so you don't miss any future events. We do have another event at the end of this week, which is on our LinkedIn page. So that link should be in the comment section as well, and that's on the burden of incontinence on the NHS and how good continence care is crucial. So we'd love for you to join us for that as well. Thank you all for watching, and thank you all for your comments and questions. It's bye from me then, and Polly, thank you again. We'll see you next time. Cheers.
Thank you. Bye everybody. Thank you so much.